afternoon, ladies and gentlemen. This afternoon, we'll start with the clinical case presentation and discussion in obstetrics and gynecology. This session will be chaired by me and Professor Aete. There will be 4 speakers in this session, 2 obstetric cases and 2 gynae presentations are going to be presented. The first speaker will be Dr. Yen Nai Wu, lecturer from Defense Services Medical Academy. He is going to talk about Unlucky Lady. We can listen about very sad tragedy of a woman. I would like to call upon Dr. Yen Nai Wu to present your case.
Good afternoon, Madam Chairperson, ladies and gentlemen. I am Lieutenant Colonel Yen Nai Wu, lecturer from Obstetrics and Gynecological Department of Defense Services Medical Academy. May I present a case? Sorry, may I present my case? Captain EMA, 29 years, Gravida 2, Grade 0+1, residing at Morbi, was admitted to number 1 Defense Services Obstetric Gynecological and Children's Hospital on 5th January 2021, 2 p.m. with chief complaint of severe back pain started on 11 a.m. With brief presentation at 36 weeks of gestation. She was a graduate. She had family history of hypertension in her father. There was no history of smoking, alcohol drinking, and bitter chewing. Her past medical, surgical, and drug history were not relevant. Next slide, please. She used combined oral contraceptive pills for 1 year. On her past obstetric history, she married with an officer for 3 years. Her first pregnancy was spontaneously miscarried at 1.5 months of gestation in November 2018. There was no dilatation and curettage. On reviewing her history of present pregnancy, it was planned pregnancy. According to her last menstrual date, her majority by date on admission was 35 weeks and 1 day. It was coincide with early scan on 6 weeks. She had history of hospitalization for threatened miscarriage at 8 weeks of gestation. There was also a history of tonsillitis in her first trimester. She took regular antenatal care and uneventful second and third trimesters. On history of present illness, she suffered severe back pain, started while she was taking bath, associated with discomfort in her upper blood, mucus, and watery discharge from vagina. There was also no history of fever, cough, and sneezing. Her urinary and bowel symptoms were normal. Examination on admission revealed she was afebrile. There was no pallor, not dyspnea, 130/70 millimeter mercury, pulse rate 84 beats per minute with good SpO2. Her heart and lungs were clinically clear. On obstetric examinations, there was 36-week size uterus with single fetus, longitudinal line, breech presentation, without definite uterine contraction and uterine tenderness. Fetal head sound was well noted with strong and regular. There 2 ready 0+1 with back chain. We have considered different days, prenatally, and threatened premature labor. Immediate treatment given where IV line with injection diclofenac, ranitidine, Maxalon, dexamethasone, methanol, and fetal monitoring. Her back pain was temporarily relieved, but recurred at 4 p.m. and it was associated with vomiting. At 8 p.m., she suffered dyspnea. And at 9 p.m., patient had restless and clamping. Her blood pressure was 100/40 millimeter mercury, and she was CO2 on air was 96% and on oxygen 99%. OG, joint care with on-call physician, surgeon, and chest physician were seen. Investigations regarding investigation done where ultrasound abdomen revealed single viable 36 weeks fetus with breech presentation, no features of placenta abruption. Ultrasound chest showed left-sided pleural effusion. ECG have sinus tachycardia. Urgent chest X-ray also showed left-sided pleural effusion. Cardiotocography have reactive pattern without uterine contraction. In the ultrasound record, next slide please. This X-ray plane showing the left-sided pleural effusion. Urgent blood test results were CpO2 had neutrophil leukocytosis and hemoglobin 9.1 gram% with normal platelet. COVID-19 RDT test was negative. Next slide, please. Specialist opinions were from OG side, there was no feature of obstetric emergency. Opinions from chest physician and surgeon was massive left pleural effusion. On preparation for ultrasound-guided diagnostic pleural effusion, patient encountered cardiopulmonary arrest on 11:05 p.m. Cardiopulmonary resuscitation was done for 30 minutes, but unluckily, patient was expired on 0030 a.m. 6 January. Our clinical cause of death was circulatory collapse due to maybe due to pulmonary embolism or ruptured aortic aneurysm. Next slide. Postmortem cause of death were number 1 is shock and hemorrhage. Number 2, left-sided hemothorax with massive hematoma alongside thoracic aorta and inferior vena cava. Number 3 is spontaneous rupture of inferior vena cava. This picture showing the postmortem finding of left-sided massive thorax. Massive hematoma alongside the thoracic aorta and inferior vena cava. Next slide. This postmortem picture also shows massive hematoma alongside the thoracic aorta and inferior vena cava. This is the picture of thoracic aorta. This is the picture of esophagus, thoracic aorta, and inferior vena cava. To raise awareness of a rare and potentially devastating disease that may present during pregnancy. Next slide. We have present a brief literature. Spontaneous rupture of inferior vena cava without prior history of trauma is extremely rare, with only less than 5 reported cases in the literature. The mortality is 57 to 95% despite prompt resuscitation. Nearly 1/3 of the patient with inferior vena cava injury died even before reaching the hospital. Half of those who admitted expired despite prompt resuscitation or early operation. The usual cause of death is massive asyncronation, leading to hypovolemic shock and multi-organ failure. Patients with spontaneous rupture of inferior vena cava can present as hemopericardium, the location of rupture. Therefore, the symptoms may vary from acute chest pain, like my patient, to abdominal distension or even shock. For your attention.
Now the floor is open for questions. Yes. Okay. Dr. Yanai, will you consider us about perimortem cesarean section to save the baby's life? Perimortem cesarean section since I'm
perimortem cesarean. Okay, every time I say that again, but that means tomorrow. Every time I do your husband a bina ma machine care. Every time I tomorrow malok care about that. Perimortem cesarean section ura. Say that again,
The CPR lori so in perimortem cesarean section low like that effective CPR for we don't load nine about no. Okay, that is a one point we need to consider. Histology po di la mati aorta ne inferior vena cava. Histology ko pa pure the labor. Spontaneous ruptures or tuma traumatic history mishiu, other history mishiu, back pain never lares. So postmortem specimen histology po di last year.
But give our confirm the photo history and she blew then IBC histology IBC rupture confirmed to be a postmortem finding out.
The case mazi risk factor ya bari shile.
Oh, my risk factors they are tomorrow the patient or risk factor tomorrow new mayor history like it usamara tomorrow risk factor literature solution mostly trauma blood or penetrating injury to inferior vena cava mostly connective tissue disorders as any male now to retroperitoneal patient no precipitating etiology to let we have
his presentation and we are so sorry for the delay. I will
sorry, speaker, baby,
thank you so much, Lieutenant Colonel Yanai, for your very sad and unlucky women. Thank you.
Thank you, Alu.
Okay. I'd like to call the next speaker, Dr. Tse Wing Han. She got a master degree of ONG in 2015, and she finished the doctorate degree of the oncology in 2019. She is working as a consultant in Central Women Hospital. So welcome, Dr. Tse Wing Han, for your presentation.
Good evening, all of my professors, my senior and junior colleagues. I am Dr. Desing Han, Central Women Hospital, Yangon, and I would like to present a very interesting case of our hospital. My topic is the teenage malignancy. KTZ, 15 years old girl, presented with the irregular bleeding by vagina for 2 months, and something protruding in the vagina with sense or incomplete maturation for 2 weeks. Her menarche is at 13 years and regularly menstruated before this clinical presentation, and she had no relevant history of bleeding disorder. On examination, generally she looked normal female external appearance. On abdominal examination, there was no palpable mass. On one finger BE, uterus was about 14-week size and soft tissue growth about 5 into 6 centimeter protruded through the ox and filled in the vaginal canal. Ultrasound described that the uterus was 12 into 4 centimeter with echogenic SOL about 5.2 into 1.9 centimeter in the endometrial cavity, extending down to the cervical canal. Polypectomy and diagnostic DNC was done on 30th April 2020 by the junior consultant, and the findings show infected cervical polyp about 6 into 4 centimeter rising from the posterior lip of the cervix, and uterus was enlarged about 12-week size with thickened endometrium. The biopsy report revealed the inflamed endocervical polyp with endometrial hyperplasia and no features of malignancy. Recurrent episode occurred within 1.5 months after first-time polypectomy. There was similar clinical findings show the uterus about 14-week size and fleshy endometrial polyp was protruded. Hysteroscopy and polypectomy was done on 24 June 2020 by the same consultant. The findings show cervix looked normal, cervical canal filled with the polyp, multiple endometrial polyp arising from the lower part of the uterus and very friable. The biopsy was infected endometrial polyp. Third episode occurred 2 months after second-time polypectomy. There are also similar clinical findings about endometrial polyp 4 into 5 centimeter. Second-time hysteroscopy and polypectomy was done on 4 September 2020. Centimeter with thickened endometrium, embryonal rhabdomyosarcoma and atypical adenofibroma. IC staining was proceeded to was strongly positive that A1 and A3 were just staining. KIN67. So the result favored origin. Because of malignancy in young age and the rare type of this tumor, JCC meeting was done. Patient had screen share မဖြစ်ဘူးလားမသိဘူး
မဖြစ်ထားဘူးခင်ဗျ screen share လုပ်ပေးပါ
မြင်ရပြီလားမသိဘူး
ရပါပြီ
ရပြီ
Because of malignancy in young age and rare type of this tumor, JCC meeting was done. Patient had another episode of bleeding by vagina again 1 month later of the last operation, and there was regrowing of the tumor. Therefore, surgical management was proceeded after thorough counseling. Laparotomy was done on 11 November 2020 by the senior gynecologist. The operative findings show there was no ascites fluid. The uterus was about 14-week size and large polypoidal mass 6 into 7 centimeter rising from the ventus and filled the whole endometrial cavity and down to the endocervix. The ectocervical ring looked normal, both tubes and ovaries were normal, and there was no palpable pelvic lymph node. This slide shows the post-operative finding. TH, PSO, peritoneal watching cytology, and omental biopsy were done. Biopsy revealed that the uterine adenosarcoma situated at the ventus invading the inner half of the myometrium with the lymphovascular space invasion, but low mitotic activity and no sarcomatous overgrowth. So it was diagnosed as uterine adenosarcoma stage 1B. Second time, IC staining was proceeded for smooth muscle actin and desmin. Both results were negative for the given tissue. It means the mesenchymal origin of the tumor tissue is homologous to the uterus. Her post-operative period was uneventful and referred to medical oncology for the adjuvant chemotherapy. Now she took second cycle of chemotherapy on 15 January 2020, the combination of the ifosfamide and adriamycin. Literature review. This tumor is the combination of the benign epithelial lining and the malignant mesenchymal component. Therefore, this tumor is halfway along the mixed Mullerian tumor, adenofibroma at one end and the carcinosarcoma at the other end. Firstly, it was described by the Clement and Scully in 1974. The incidence is 5.5 to 9% and only situated only 1% of the genital tract malignancy. The incidence is peak in the 50 to 60 years of age. Clinical features, the most common presenting symptom is the abnormal vaginal bleeding, about 71%. It can also present as the pelvic mass, uterine polyp, abdominal pain, foul smelling, vaginal discharge, and the pelvic pressure symptom. Ultrasound scan show the large heterogeneous mass occupying the whole uterine cavity. In MRI, it can be described as a markedly enlarged uterus with thin myometrium due to the occupying of a large polypoidal mass. Pathological findings, microscopically, the stroma typically concentrate around the gland, periglandular curving, so it can distinguish from its benign counterpart, adenofibroma. Majority of the sarcomatous component is endometrial stromal sarcoma, but about 1/4 of cases, heterologous mesenchyma can be present. Adenosarcoma is mostly originating from the endometrium, but it can also present from the myometrium and the endocervix. This slide shows the periglandular curving. So it can be considered to be less aggressive and more favorable prognosis than the carcinosarcoma. If the sarcomatous component is at least 25% of the tumor, it can be defined as the adenosarcoma with sarcomatous overgrowth. IC staining, cell proliferation markers of Ki67 and P53 are stronger in adenosarcoma with sarcomatous overgrowth. But in typical adenosarcoma, CD10 and progesterone receptor are very higher. Estrogen and progesterone receptor expression were higher in typical adenosarcoma. In this case, there are good prognostic factors, young age, and no lymph node involvement and margin clearance, and the no sarcomatous overgrowth. But this has poor prognostic factors of myometrial invasion and the lymphovascular space invasion. According to the FICO report 2018, this case was diagnosed as the stage 1B due to the inner half of the myometrial invasion. According to 5-year survival and recurrence, for the stage 1, survival rate is 79% and decreasing to 48% for the stage 3. Adenosarcoma with sarcomatous overgrowth has higher mortality and higher rate of recurrence. Regarding surgical treatment, surgery is the main treatment. TAH-BSO is the standard surgical care. Limb adenectomy is still controversial. Regarding the chemotherapy, the overall survival was only influenced by the surgery and no impact of the chemotherapy, palliative radiotherapy, and the hormonal. Progression-free survival was better for the combination therapy of the doxorubicin and the adriamycin. Travadatin can be used in the relapse cases of the adenosarcoma. Hormonal treatment, high-dose progesterone, medroxyprogesterone, acetate, and megestrol, and the aromatase inhibitors can also be used, especially for the receptor-positive patient. Radiotherapy, then no benefit in overall survival in resected uterine adenosarcoma, therefore not recommended for the routine use. Those are references, and thank you very much for your attention.
Sorry for the problem of sharing the slides at the beginning, and we lost our concentration. Actually, it is very interesting case of malignancy in young age. 15 years old presented with the recurrent episode of bleeding and passing of the polyp-like growth. There are 3 histological findings. The last finding found out malignancy. It is the adenosarcoma, isn't it? I want to wind up the scenario. And then finally, and then she worked out to get the diagnosis behind doing the histological chemistry assay, and the HBSO and chemotherapy was done. So any questions are welcome.
And may I know about the prognosis of your particular patient?
Yes,
Your patient.
This patient has good prognostic features because she is young age and there is no the sarcomatous overgrowth and the lymph node involvement and the surgical margin clearance. So surgery is completely in this case. Therefore, those features are good prognostic.
Adenosarcoma with the sarcomatous overgrowth is the aggressive nature. Here, there is no such sarcoma overgrowth. So please explain what is the sarcoma overgrowth, Dr. Tesungwehan.
Sarcomatous overgrowth လို့ပြောဖို့အတွက်ဆိုရင်အနည်းဆုံးဒီ mesenchymal origin မှာ sarcoma component က at least 25% ပါရပါမယ်မမ
Adenosarcoma is the rare sarcoma, leiomyosarcoma is the commonest, and endometrial sarcoma is the second. So that's why we want to present this rare case. Any questions from the audience? No queue. If there is no more questions, I will call the third speaker.
That speaker is Dr. Luen Weng Khai, Specialist Assistant Surgeon from North Oklahoma General and Teaching Hospital. She's going to present about the obstetrics trauma. May I call upon Dr. Luen Weng Khai to present about your case.
Mama သစင်ဝင်းဟန်ရှင်ဟို stop share လေးလုပ်ပေးပါမမဟုတ်ကဲ့ Mama screen မဲပေါ်နေလို့
သမီးကဟိုကလုပ်လိုက်တော့ဖြုတ်လိုက်တော့
Good evening, Madam Chairpersons and other participants. I am Dr. Luen Weng Khai, Specialist Assistant Surgeon, Obstetrics and Gynecology from University of Medicine 2. I would like to present a case of a lady with severe birth-related trauma. She is a 36 years old gravid 2 priority 1+0 lady from Tenterpin Township, admitted to our hospital at 3 p.m. on 6 November 2020. She was referred from Blantyre Hospital for hypovolemic shock at the second stage of labor with urethral tear and bladder tear and 4th-degree perineal tears with attempted home delivery. Her NMP was anal. According to 32-week scan, her maturity was 41 weeks and 5 days. She took antenatal care at MCH for only one time. She got married at the age of 32 years and single marriage. Her first child was born by spontaneous vaginal delivery at 8 months of gestation at home. Only neonatal death occurred at day 2, that anal birthway. In this pregnancy, the labor pain was started at 9 a.m. on 6 November 2020. The woman and her family chose home delivery by TBA. At about 1 p.m., the perineum was kept by TBA with a sharp blade to deliver the baby. With massive bleeding and failure to deliver the baby, she was admitted to Blantyre Hospital at 2 p.m. on 6 November 2020. At Lantana Hospital, she was in shock with a blood pressure of 65 per patient and pulse rate of 120 beats per minute. Abdominal examination revealed a 10-size single fetus longitudinal line baby with uncertain viability. Vaginal examination revealed a cervical dilatation of 8 cm with station 0 and liga mixed with shoe. There were urethral or bladder tear and 4th-degree perineal tears. At Lantana Hospital, initial resuscitation was done and indwelling catheterization was also done. With blood transfusion, she was referred to Noel Clarke General and Teaching Hospital. On admission at our hospital, she was febrile with fever of 100 degrees Fahrenheit with marked Bella. Blood pressure was 130 by 80 mm mercury and pulse rate of 140 beats per minute. Abdominal examination revealed a 10-size single fetus longitudinal line baby with absent fetus sound. Fetal head sound. Vaginal examination revealed a fully dilated cervix with station 0+1, and the baby was aortic position with a cupping of 3 × 3 cm with grade 2 molding. Liga was not obtained. There were blood-stained urine of 100 cc in the urine bag. 15 minutes after arrival to our hospital at 3:15 p.m., a female fresh SB 3.3 kg baby was delivered vaginally. The stage of labor was uneventful. After delivery of the baby, there were multiple perineal tears, including the anterior vaginal wall tear, together with urethral tear or bladder tears, and there were also 4th-degree perineal tear. Urethral and bladder tear exposing the catheter balloon in vagina in this figure. With multidisciplinary team approach by obstetrician and gynecologists, general surgeons, urosurgeons, anesthetists, and physicians. The repair of the injuries were done by 3 teams under the combined spinal epidural anesthesia. The operation time was 6 hours and 20 minutes. Surgical team, the finding was 4th-degree perineal tear and temporary sigmoid loop colostomy and inner sphincter apposition was done by surgical team. Neurosurgical team also attended the operation. Their findings were as follows. Bladder neck was cut from the urethra with a posterior bladder wall injury, including the triangle, which was 4 cm in length, and there were also anterior bladder wall injury 2 cm in length. Bladder repair with formal suprapubic catheterization and bilateral G-stent insertion through the midline abdominal incision. This figure shows the bladder repair with formal suprapubic catheter and bilateral G-stent insertion. In OG10, the findings through the abdominal approach reveal uterus, both tubes and ovaries were intact. Through the perineal approach, there was a cervical tear about 3 cm and multiple anterior vaginal wall and lateral vaginal wall tears with 4th-degree perineal tear of 6 cm. The repair of cervical tear and vaginal wall tears, repair of the rectal mucosa, internal and external anus sphincters repair, and vaginal mucosa, perineal muscle tears repair were done. These 2 figures show after repair of the injury. The first figure shows temporary loop colostomy and repair of the bladder injury through the abdominal incision. The second figure shows after repair of the 4th-degree perineal tear. She was transfused whole blood of 4 units, PEG of 2 units, and PRP of 1 unit within 48 hours. Parenteral antibiotics were given, and thromboprophylaxis was also given for 10 days. Her post-op period was uneventful, and she was discharged on 12 post-op day. Indwelling catheter was removed after 3 weeks, and suprapubic catheter was removed after 4 weeks. The colostomy closure is planned on 25th January 2021. No urinary and fecal incontinence occurred at 2 months follow-up. Implant insertion was done for family planning. Literature review. Birth-related perineal trauma has many risk factors, as we all know, like maternal age, low puberty, instrumental deliveries, and birth weight of more than 4 kg and prolonged second stage of labor. Inadequate management of this injury can cause severe complication. For acute complication, it can cause hemorrhage and puerperal sepsis. For chronic complication, pelvic floor disorders such as urinary and fecal incontinence, persistent pain like dyspareunia and prolapse can occur. Birth-related perineal trauma is also likely to be increased in poorer setting because of limited access to the adequate resources such as optimal suturing materials and poor environmental and household circumstances and lack of sanitation and malnutrition. Approximately 1.3 million women give birth each year in Myanmar. Home delivery was 64% and institutional delivery was only 36%. At rural areas, 90% of deliveries still occur at home. 50% are attended by TBAs. These traditional birth attendants were the most common delivery assistants in the private sector. In this case, the TBA is unscathed and lack of the training. The woman and family member choose home delivery because of the social reasons. Financial difficulties and transportation-related barriers were not found in this case. A hospital-based cross-sectional descriptive study at our hospital in 2018, the most common reasons for attempted home deliveries are local availability and familiarity in 26.3%, followed by financial problem in 22.8%. The mode of delivery in this study show 47% are born by emergency LSCS and 34% by normal delivery and 18% by instrumental deliveries. For the perinatal outcomes, 3.6% of attempted home delivery are stay-based and 3.8% occur early neonatal death. The reported incidence of obstetric-associated bladder injury is rare and it is between 0.14% and 0.94%. The overall prognosis depends on other injuries, but when the pelvic floor is injured, like in our cases, some patients may develop urinary incontinence in their life. Overall incidence of the obstetric anal sphincter injuries occur in 6.1% in primipara compared with 1.7% in multipara. 60 to 80% of women are asymptomatic at 12 months following delivery and repair. The severe anatomical disruption of rectal mucosa seen in this patient warranted a temporary loop colostomy to protect the repair. She was managed by a multidisciplinary team, including urologists, surgeon, and gynecologists. Physiotherapy and psychological supports were also provided. In conclusion, among the highest worldwide maternal mortality ratio, the majority of mortality and morbidity were being associated with a lack of trained supervision at delivery. Because of the home delivery by unscathed person, maternal morbidities like vaginal prolapse or puerperal psychosis can cause unwanted physical, mental, social, and economic consequences for respective families. Severe perineal trauma is preventable in some extent, but an unfortunate outcome of vaginal delivery. Both obstetric anal sphincter injuries and bladder injury can be reduced by improving practice, training, and provision of high-quality care in order to reduce the long-term morbidity. And these are my references. And thank you for your attention.
Thank you, Dr. Liming Kai. The case Limali, Daro, Yamadi Maro, no, the birth trauma, no, home delivery, Miare, Jamulo, not Pinia Mava. The case Lima to home delivery, no, attempt look at Chima, no, vagina manipulation, you look at the la, no, like I out at Chima, no, vaginally, no, Muibu, try look at the la, but don't let's the case card, Yao Cloud, Yao BBG and Blama Jau, or Muiduarali at a Jamulova. The vagina manipulation, Palau look at the attempted home delivery, ma, Palauti, no, look at the history.
Okay, Shamma. To our own case car of one, to a Manakuna, my paisana, Bios, and I love here Sabio, the TV in a attempt look by ma, a Mazia or a to our meter 9 will not stand a two Kanakana Stamare. Now, what later domains of your let it while TV shall be told Naimaro. ဘောနော်ကလေးထွက်တော့မယ်ဆိုပြီးတော့သူ့ရဲ့ perineum ကိုနာတယ်ပေါ့နော်ဓာတ်နဲ့ဖြတ်လိုက်တယ်လို့ပြောပါတယ်မမအဲ့ဒါပြီးတော့ခဏနေတော့ကလေးလည်းမထွက်ဘူးသူလည်းမူးလာတယ်မောလာတယ်ဆိုတော့သူ့ကိုလှိုင်းသာယာဆေးရုံခေါ်သွားပါတယ်လှိုင်းသာယာဆေးရုံလည်းသူတို့ရွာနဲ့ဆိုလို့ရှိရင်တော့ဟိုဟာလောက်ပဲ15မိနစ်20လောက်ပဲသွားရတယ်လို့ပြောပါတယ်မမလှိုင်းသာယာရောက်တော့ patient in shock ဖြစ်နေတယ်အောက်မှာလည်း perineal trauma တွေအများကြီးနဲ့ဆိုပြီးတော့ resuscitate လုပ် blood transfusion နဲ့ဟိုညီတို့ဆေးရုံထွက်လိုက်တာပါမမသူတို့ကတိတာထည့်တယ်ရတော့ကတိတာဘလုံးကဟိုဟာပေါ့နော် တေချာထည့်ရတာလည်းအဆင်မပြေဘူးပေါ့နောက်ကလေးကလည်း Oscar သူတို့စီမှာတော့ 8 cm နဲ့ဆိုပြီးတော့သမီးတို့စီကိုလွှဲလိုက်တာပါမရောက်ပြီးတော့သမီးတို့စီရောက်တော့ဟိုပါပေါ့ချက်ချင်းပဲတိတ်မကြဘူး15မိနစ်အတွင်းမှာပဲ assess လုပ်နေမယ် deliver လုပ်သွားတာပါမ instrumental delivery တောင်မလုပ်လိုက်ပါဘူးဟုတ်ကဲ့
What about the long-term prognosis of this particular case?
ဒီ case မှာဆိုလို့ရှိရင်တော့ long term ကတော့သူ့ရဲ့ဒီ bladder injury နဲ့ urethral injury တွေကတော့ပေါ့နော်သူ pelvic floor injury ဘယ်လောက်ဆိုးလဲပေါ်မှာမူတည်ပြီးတော့ဟို life long မှာတော့ incontinence ရနိုင်တယ်လို့တော့ပြောထားပါတယ်မမဒါပေမဲ့ patient ကတော့အခုဟို catheter တွေပါဖြုတ်ထားတာတော့3ပတ်ကျော်သွားပါပြီအခုထိတော့သူက urinary symptom တော့အဲ့လိုမျိုး incontinence တွေပါရှိနေတာတော့မရှိပါဘူးမမသမီးနဲ့တော့အဆက်အသွယ်ရပါတယ်ကဲရှင်ဟို colostomy ကတော့ဒီနေ့မှပိတ်တာဆိုတော့ဒီ fecal incontinence ကတော့ဆက်ပြီးတော့ကြည့်ရပါအောင်မယ်မမကဲ
The future pregnancy အတွက်ကိုဘာတွေ suggest လုပ်ချင်ပါလဲ
ဟုတ်ကဲ့ရှင်မသူ့ကို proper တော့သူကလည်းပေါ့နော်သူ psychologically မှာနည်းနည်း trauma ရသွားတဲ့အတွက်လောလောဆယ်တော့သူ claim မယူခြင်းဆိုတော့တမီးတို့ consult လုပ်ပြီးတော့ data consult လုပ်ပြီးတော့ implant တော့သူ့ကိုထည့်ပေးလိုက်ပါတယ်မမပြီးတဲ့အခါကျရင်တော့ next pregnancy ကတော့သူက perineal injury အရင်ဆိုးထားတာဖြစ်တဲ့အတွက်တော့cesarean section နဲ့ဟိုဒီလို hospital ပေါ့နော်ဟို facility care တေချာရှိတဲ့ hospital တွေမှာမွေးဖို့အတွက်တော့သူ့ကိုတေချာ counseling လုပ်ထားပါတယ်။ဘာလို့ဆိုတော့ bladder injury လည်းရထားတာဖြစ်တဲ့အတွက် CSR လုပ်မယ်ဆိုရင်တော့မှဟိုဒီပေါ့နော်ကျွမ်းကျင်တဲ့လူကလုပ်ဖို့လိုအပ်ပါတယ်ရှင်မဟုတ်ကဲ့
If there is no more questions, we will move on to the fourth speaker.
I'd like to call the last speaker, last but not the least, Dr. Wei Pyo Mao. And he got a MBBS degree in 2007 and master degree in 2013. He had a fellowship training in Siriraj Hospital, Bangkok, Thailand for 1 year. And he is working as a consultant OG and gynecologic endoscopy unit, Central Women Hospital, Mandalay. I'd like to call Wei Pyo Mao for your audition.
Good afternoon, Madam Chair, ladies and gentlemen. Today, I would like to present a topic on demystifying the hysteroscopy. This is our inpatient hospital statistics of our Central Women Hospital, Mandalay. We usually perform more than 100 cases per year. And in 2018 and 2019, the number of hysteroscopy cases were a little bit decreased because we are moving towards the outpatient hysteroscopy. We start our outpatient hysteroscopy clinic from May 2018, and we perform 58 cases in 2018 and 96 cases in 2019. And we perform a variety of hysteroscopic surgery cases, starting from simple cases like diagnostic hysteroscopy and hysteroscopy-directed endometrial biopsy to more advanced cases like hysteroscopic recessions of myoma and hysteroscopic ablations. This is our outpatient hysteroscopy setup. We prefer to use IM or bioreactor diclofenac half hour before the operation and paracervical or intracervical block for anesthesia. For distension media, we prefer to use normal saline. For hysteroscope, we use a miniature hysteroscope, STOTS 2.9 millimeter 30-degree scope with 3.5 millimeter sheet. And for the instrument, we use a 3-friend instrument. If we don't use no paracervical block, we start with the vaginoscopy first, then proceed to the hysteroscopy. This is our outpatient hysteroscopy setup. Previously, we use a 4 millimeter scope. Then we shift to the 2.9 millimeter scope. With this scope, the patient is very comfortable. For the fluid management system, we have 2 expensive fluid management systems from STOTS and Richard Wood, but I prefer to use this simple one from C-Fuser from Metex. For the diagnostic hysteroscopy, we usually use a 500 ml NS, and for operated hysteroscopy, we use a 1000 ml NS. This is we also do the tubal patency test during the hysteroscopy. This is tubal patency, we can do the test the tubal patency during hysteroscopy. If the air bubbles going inside the tubal ostia, the tube is open. I prefer to inject the air bubble with the butterfly needle from the side tube. If the tube is blocked, we then proceed to the tubal cannulation together with the laparoscopy and chromopacubation. This is a good catheter. For the good catheter, it has the outer catheter and inner catheter. So we firstly insert the outer catheter first, then advance the inner catheter with the guide wire, then remove the guide wire and inject the dye through the inner catheter. Then we check with the laparoscopy. This is the malposition of the IUCD, because if we find only part of the IUCD is seen, we should consider the laparoscopy, because we have 3 cases in which the IUCD was inside, part of the IUCD was inside the small bowel, and 1 cases, the IUCD was inside the serosa of the bladder. Luckily, 3 of the 4 cases can be managed with laparoscopy. This is a multiple IUCD fragments. Sometimes the IUCD maybe have a multiple fragment if it is inserted a long time ago. So if in the difficult cases, we can use the optical grasper that neurosurgeons use for ureteric catheter removal. In these cases, the patient complained with presenting with the recurrent miscarriage. During the hysteroscopy, we found the intrauterine septum. So if the septum is small, we can simply cut with the scissor. But if the septum is large, we prefer to do the septal recession with the Basel point, which is a bipolar electrode. This is our after excisions of the uterine septum. So as a post-operative management, we prefer to insert the IUCD, copper IUCD, after removing the copper from the IUD to prevent the adhesion. This is the uterus diaphus. This patient have 2 vagina, 2 cervix, and 2 uterine fenders. These are the intrauterine adhesion from the previous infections. This is also the severe endometritis. You can see that there are hemorrhagic area occupying all over the uterus. This is a chronic endometritis. In this case, the chronic endometritis is the emerging causes of the recurrent miscarriage and recurrent implantation failure. We can also inject the methylene blue during the hysteroscopy, and these lesions will be stained with the methylene blue. If you took the biopsy from this area and sent for histopathological examination, you may see that the plasma cell infiltration into the endometrium. This is atrophic endometritis. You can see that the endometrium is thin and atrophic, and you can also see the small capillary with unsupported tissues. So usually the bleeding is from this capillary. So when we reduce the intrauterine pressure, sometimes the bleeding from the capillary can be seen. This is the endometrial polyp and myomatous polyp. For the endometrial polyp, we prefer to small polyp. We prefer to do at the outpatient hysteroscopy. For myomatous polyp, we prefer to do the hysteroscopy resection and the spinal anesthesia. This is an endometrial polyp. For the small polyp, we can simply cut with the scissor, or sometimes you can pull with the grasper. You can see there is no bleeding. For a larger stalk, we prefer to use the bipolar electrode from Basel point. And if there is a multiple endometrial polyp, we should be beware of the atypia, because so we need to take the biopsy not only from the polyp, but also from the remaining endometrium to exclude the coexisting endometrial cancer. This is a Basa point system we use for hysteroscopic resection. This is a transvagal recessions of the myoma. For the transvagal resection of the myoma, usually start with the simple cases like type 0, which is the myoma is completely intracavitary, or type 1, more than 50% in the endometrium, and so endometrial cavity. So we can start with the simple one. So to reduce the bleeding, we can inject the intracervical vasopressin or telepressin. So sometimes the mass is so big, so you can consider the two-step operation, because when you take the operation for the long time, there is a risk of pulmonary edema. For the take-home message, the hysteroscopy is simple and effective way to diagnose and treat the intrauterine pathology. So you just start with the simple cases and then proceed to the advanced cases. So advice from the experienced person is usually helpful. Thank you for your attention.
Thank you very much, Dr. Wee Pyo Maung, for your comprehensive presentation and colorful picture and video. So if you want, audience, if you want to ask the questions, please write the questions through the chat box. Your presentation is so clear. There is no.
What about your? What about I would like to ask one question. What about your complications rate? And which complications have you encountered so far?
Actually, for my cases, the cases I have been performed, and there is very few minor complications, like the post-operative fever, or for maybe 1 or 2 days. That's all. But for the junior, that they are experienced person, I think they got uterine perforation for maybe 2 cases. And last 2 years.
For office hysteroscopy, how long do you keep the patients after the procedure? How many hours?
No, for the office hysteroscopy, I usually keep for only half an hour to 1 hour.
Yes.
Because they are usually mobile. So after the procedure, they can wait outside. And after 1 hour, they can go home. Usually, they are the OBD cases, and they usually the consultant from the gynae OBD, they select the cases and send to our outpatient hysteroscopy clinic.
Okay. Have you encountered IUCD inserted in China? So no tail, but only ring.
Yes, they have only 2 kinds.
Yes.
In China. One is a circular IUCD.
Yeah.
Circular IUCD, circular IUCD with the copper around it. So it's sometimes I use a hook to hook the ring and remove it. So it's one of the easy way to remove, or maybe you can grasp the grasper. Sometimes if you don't have a hysteroscopy, we can insert a small hook inside the uterine cavity and can remove it.
Yeah.
So another one is I think maybe oval shape or uterine cavity shape IUD from the China. Yeah. So I think one of the easier thing to remove is that because they are the complete cycle. So you can hook the IUD and you can put it out.
Okay.
If there are no more questions, I want to conclude this clinical sections. First of all, I'd like to wind up all the 4 presentations. The first speaker talk about the unlucky lady. That is the very rare cases of spontaneous rupture of inferior vena cava. And that is quite interesting, but unfortunately, we cannot see the slides clearly, so we lost our concentrations. The second speaker focused on the oncology aspect. That is the uterine adenosarcoma in young age. Third speaker focused on the safe motherhood issue. That is the reproductive health issue. We can see how importance of the skilled birth attendants, and if we need to reduce the maternal morbidity and mortality, we need to train all the birth attendants to be skillful. The last speaker is specialized in endoscopy and hysteroscopic treatment and investigations. And we can get the diagnosis as well as therapeutic as well. So I would like to congratulate all 4 speakers and who present all the presentation within the time limit. And I also thankful to all participants who discussed the presentation. Thank you very much.